So this morning, I'm going to talk about how our kids different and go over some things that you can't read in books. Our textbooks are full of things about fracture angulations and what's acceptable and what's not acceptable and which fractures need surgery and which ones don't. So I want to take our time together to this morning to go over some things that are non-obvious that you really can't read in books. So, I think the first is that, kids will not always make you look good. There's this idea sometimes that adult orthopedic surgeons say that, oh, it's a kid, he's going to do great. I can assure you that that is not true. Here's a wound breakdown in a 7-year-old with exposed nerve. Here's a kid who had an elbow fracture, who had a significant contracture here. And here's a hook nail deformity from a fingertip injury. So, these are all things that are not good. Here's a pin on a supracondylar placed through an ulnar nerve. So, kids won't always make you look good. Just remember that. Don't think just because you're taking care of a child that you can just do whatever you want and the kid's gonna have a good outcome and that you don't need to worry about details. So the way that kids are different that are relevant to clinical care, how they're different physiologically, how they're different socially, and how we manage their aftercare. So first, children are different all the way around physiologically. The saying that Mercer Rang said, children are not just little adults, rings quite true, and that becomes more true the younger they are. The bone is different, the physis is present. There's periosteum that plays a huge role in fracture and injury management. The blood vessels are different and the nerves are different. So let's start with some of the basics. So the bone is different. So here's an injury film. And Kara, are you available to take a look at this injury film?
Yes, sir, I am.
All right, Kara, so tell us what you see here.
So I see more like an AP of a forearm in a skeletally immature patient. Just trying to look here. What I would gander is that there's probably either a physeal injury, like a subtle physeal injury, or I think there'd be like a distal radius or
Take a look at that elbow.
the elbow. A little bit of a fat pad. Did you give the age of the child or no? I'm assuming that they're over 5, so I think the anterior humeral line is appropriately bisecting the capitellum.
What do you think of that radial head?
It is anteriorly subluxed to the capitellum.
Yeah. So what kind of injury is this?
So it's it's probably either an isolated radial head dislocation or more likely, I'm not seeing any fractures along the shaft, so I don't think I'd classify it as a Montasia. But
so I just dropped a straight line here on the ulna for you.
Yes, sir.
So you don't see any fractures along the ulna, but what do you see?
There is a bit of a bow, so there's probably a green stick
type injury,
Sorry, sir.
The ulna is just bent.
Yes, sir.
So so you've identified that correctly. This is a Montasia type injury, but the ulna is bent here. And so this illustrates one of the pediatric physiologic principles of bone that's important to remember is that it can plastically bend. So here you have a bent ulna. This is a Montasia variant here. And you can see it's not that easy to pick up what the injury is here quick because there's not a broken fracture line. But you have a bent ulna here, and that's why you have a dislocated radial head in this case. Here's another injury where this is a very common injury. Anybody know what this is?
Almost looks like a buckle.
Just a radius fracture. It's buckle fracture.
Yeah, it's a buckle fracture, right? So this is a buckle fracture. This is a fracture that's unique to growing bone because of the softness of the pediatric bone. And so you see on the volar cortex there's no actual fracture line. It just bends on the volar cortex. And on the dorsal cortex, it just buckles, it just squishes down. So briefly, while we have a buckle fracture x-ray up, I will mention the evidence-based treatment for buccal fractures, which is a removable wrist brace, no repeat x-rays and no follow-up. That has been shown in multiple level 1 studies, level 1 and level 2 studies. I think the real future that we all would like to see with buccal fractures is that these do not get a referral to ortho. Patients are simply provided home education and have no follow-up. Just given the high volume of these and the lack of any effect of any intervention, how it doesn't change outcomes at all. Here's an example. I pulled this off of one of my friend's Facebook pages a couple of years ago. This is what happens when you give adult-style treatment for a kid. So, here's his x-ray. I mean, clearly it's an obvious buccal fracture. And he's in a sugar tong. Look how far that sugar tong goes. You can't even see his pinky. So he's got a sugar tong that's, all the way out and a sling. And so, I mean, this is what happens. You just burden parents with this treatment that's totally unnecessary. A sugar tong splint, a sling, a visit to the orthopedic specialist. And that's why this is just, over treatment. So we don't give adult style treatments for kids. This plastic deformation can be a real problem. You can get these other injuries here. So James, what do you see here?
There's an olecranon fracture.
Okay. What else?
See, I'm trying to see if the radial head's lined up with the capitellum, but capitellum's not ossified.
Oh, the capitellum is ossified.
It's okay. So it's sublux. So it's another Monteja variant.
Yes, this is the Monteja variant, right? So, but there's no complete fracture line through the ulna. We've got essentially this buccal type fracture through the ulna. So this is a plastic deformation problem. So to illustrate, how difficult these plastic deformation problems can be. So here we have an arthrogram. So here's this kid. Here's his arthrogram. And you can see the radial head is still dislocated here. You can see how it's anteriorly dislocated. And when we hold them up into hyperflexion, the radial head will reduce. But the minute you let go of it, boom, that radial head pops right back out again. So even though the ulna looks like it's unfractured, but you can see here in this lateral fluoroscopic image that clearly the ulna has a big bow to it, right? It's clearly very bent. So to overcome this has to be treated with an osteotomy, an acute osteotomy. Make a cut, you let that ulna go into some flexion, and then fix it in that new position. So we're letting the ulna heal what presumably looks like crooked here, but the radiocapitellar joint is reduced. But the bow here, the proximal bow of this ulna, matches the distal bow of the plastic deformity that occurred during the injury. So the elbow stays located now. Here he is, full range of motion, full pronation, full supination. So another thing that occurs in pediatric bone that's different than adults is remodeling. So, here's a distal radius fracture, 20 degrees angulated, that we might say in an adult, would end up causing a, distal radius malunion and a dizzy deformity and wrist pain and post-traumatic arthritis. But in a kid, here he is a year later, it grows back. And it grows back because of the pressures applied on the physis by the loaded joint. It slows down one part of the physis and speeds up the other. And so it grows back into anatomic alignment with time. This can be very impressive in kids, which if you haven't actually seen or taken care of these cases, is not intuitive. So here's one. This was a younger kid, about 4 years old. So here he is. He's got this both bone form fracture. We get it reduced. It comes back like this. And in an adult, this would be a problem because of the loss of the radial bow here. So here he is. It goes on to heal with no radial bow. Here he is 2 years later. And here he is. Full extension, full flexion, full pronation, and full supination. So the remodeling power of children is quite powerful, but it is age dependent. So younger kids are going to remodel more than older kids, and not every injury will remodel, right? A dislocated radial head is not going to remodel. but that distal radius, this built bone forearm, these will remodel with time. So another principle to consider in pediatric fracture management is the periosteum, and this rarely plays a role in adult fractures, but in children, it plays a central role. Because the bones are surrounded by this thick leather-like rind, it can act as a internal splint for you. So here's a image taken from Rang's Fractures in Children, which shows how the bones will buttonhole through the periosteum, but once you get them reduced, help to apply a reduction moment with something like a 3-point mold. That's why, for example, when you go to mold your fractures, they hold nicely in reduction and they don't go the other direction, because here in this case your periosteum that's intact is serving as a internal tension band. So the periosteum can also be problematic for fracture reduction. So here is a Salter-Harris 2 distal radius with dorsal displacement, sort of a classic pattern. You can see that volar metaphyseal spike. Here's the injury films. So, we try to take it through a closed reduction. Here's the finger pushing on it, and it just won't go. Just won't go, just won't go, just won't go. So James, why won't it go? Because someone didn't push hard enough?
Sir.
Yeah,
No,
interposed periosteum, exactly. And so this can be a frustration of second and third year residents in the ER. They feel like they're just not trying hard enough, that it represents some sort of personal or character failure, that they're unable to get this thing reduced. But in reality, the irreducibility of it is a reflection of the mechanism and the physiology and the forces at play. And here's what it looks like when you make an open incision on this. So this is what I like to call the naked metaphysis sign. That as you're looking here, you see this piece of naked metaphysis. It has nothing covering it. It has no periosteum. It has no muscle attachments. That's just naked metaphyseal bone. And what that is that's the metaphysis that has buttonholed volarly. The periosteum is behind it in the fracture site, and all you can see here is the bone of the metaphysis. So in this case, we perform an open reduction. We haul those pieces out, and then it's treated with a simple pinning. Here's another one. Same thing. There's that naked metaphysis sign where all you can see is metaphyseal bone. And this one has a bit of pronator quadratus interposed as well. As you can see, there's muscle here distally. So the periosteum also plays a role in fracture healing. So I want to show the result here. In this case, this is a widely displaced pediatric supracondylar treated with cross pinning. So I want you to take a look at this lateral here, because this comes up all the time when we're going through this case. We look at this lateral and we say, oh, there's some bone in the back and it looks like it's not reduced and maybe it's not out all the way, and we worry about column views and all sorts of other things when we're pinning these elbows. But look what happens when it heals. All right, the periosteum here, when you look at the AP, has created this shroud of bone around the native metaphysis. Both on the AP and the lateral, there's this huge deposition of new bone from the periosteum. And the reason why this is important is it gives perspective to your intraoperative fluoroscopic views. That when you see this view here, especially on the lateral, and you're worried about a little cortical width here, a little cortical width there, remember that this is what this thing heals into. It blossoms into this, cloud-like covering of the native bone, which erases away any tiny little spicules of bone that are sitting out, or one or two cortical widths that are off a little bit. And so the point is that there's no value in chasing down a tiny little bit of cortical irregularity in a fracture like this, which is eventually just going to be plowed over by new bone deposition from the periosteum. So another consideration in children when taking care of injuries in children, especially as a hand surgeon, is that the blood vessels are much smaller. This is a brachial artery in a 8-year-old. The brachial artery in an 8-year-old is only going to be about 1 to 2 millimeters in diameter. It's the size of a digital nerve. It's not big. And that's a consideration when you're thinking about if you have to take a graft, if you're looking for the vessels, what your expectations should be about what their size is going to be. So you just got to remember that these things are going to be much smaller in children. They're also going to have much more adventitia on them. They're very, very thickly encased in adventitia. And because of this, they're going to be much more vasospastic. Children are, in general, much more vasospastic than adults. They're very sensitive to cold. They're sensitive to temperature. They're sensitive to epinephrine solutions. And if you're going to be doing arterial reconstructions in children, I think the number one tip I can give you is that your grafts are going to take a lot of time to pink back up. If you've got the technical skills, if you've done the case, you've done the repair, drop your tourniquet, warm the room up, and you're just going to have to wait a lot longer than you do in an adult. And that's simply because of the pediatric physiology, that they're just more vasospastic and they just take longer to break that vasospasm. With nerves, there's relatively fewer differences when it comes to nerve and nerve reconstruction. The nerves are proportionally smaller. In general, though, children will really do well with repair or grafting, even sometimes delayed. You can kind of push the limits with nerve reconstruction in children. You can do nerve reconstructions at 9 or 10 months. You can do grafts that are 7, 8, 9 centimeters. This is one here we did that was 8 centimeters of a median nerve. And so they'll still do well, but doesn't mean, though, that you can skimp on the basic principles. So this was a case here. This was sent in from outside where someone tried percutaneous pinning, a both bone forearm fracture. They ended up wrapping up the median nerve. You can see it here. We've cut out the end bulb neuroma, and we're going to do a graft. We ended up doing about a 8 centimeter graft on this one. But we still follow basic principles, right? We still cut out the neuroma. We still interpose the nerve gap with graft, with live graft. We don't skimp on the basic principles, but overall, you can expect better results in children from nerves. So moving on from the physiologic differences, I want to mention a few social differences. So you got to remember about kids, right? They're always going to be non-compliant with your physical exam, with your therapy, and they're going to be non-communicative. I mean, they're like little drunks. They really are. They're like little drunk trauma patients that show up that are going to be non-compliant and non-communicative. The good news is that when it comes to taking care of them afterwards, none of them have jobs that they have to get back to. You don't have to write work notes for children. They're not going to be trying to go out and work with their casts and their pins on. And in general, they're always insured. And so your access to things like home care and therapy if needed and return trips to surgery are going to be much better. And so in that way, they're going to be different than the adults that you take care of. So here's a great case of a child with a non-compliant physical exam. So this was a 4-year-old that fell and sustained a glass injury to the wrist. And so the phone call that I get is, oh, we got a 4-year-old. He's downstairs. He's neuro intact, but he's got a laceration on his wrist. And I said, well, what's the exam? Well, it's just non-compliant with the physical exam. So Kara, how would we manage this child that's being non-compliant with the physical exam with a laceration to the wrist?
Well, I don't think you can, first of all, call the attending and say they're neuro intact if they're not compliant with the exam. So it might warrant an OR trip just for a better exploration if you're not going to be able to understand from an exam standpoint what tendon nerve injury you might have.
Yeah, I would agree with that. And so, let me ask you this. What do you think that the true negative predictive value is of a exam like this in a child with laceration, right? If you think that the exam is negative, what do you think the chances are it really is negative on the inside?
I think fairly low. In my experience with these, it was something I was always injured.
Yeah, I think you're absolutely correct. And so, the point here is not to get lured into that. So here's what this kid ended up having. So you can see a couple of bulldogs there on the radial artery, working from top to bottom. Radial artery, FCR, median nerve, FPL, and a couple of superficial flexors. So, serious injury, glass to the wrist, non-compliant exam, and it looked innocuous. It originally externally looked innocuous, and this is a very underappreciated injury. The point is that this particular case, I think that the characterization or the thought was, oh, it's a kid, I'm sure he's fine. People think, oh, kids are always fine, and well, it was non-compliant with the exam, but overall it looked pretty good. And looking here, it quote looks pretty good, right? The fingers are perfused. You might easily miss the loss of cascade of the FPL compared to the other fingers. But like Kara pointed out, these glass injuries almost always have something serious. So if you have glass, you have non-compliant exam, you just got to take them to the OR, like Kara said, and just explore them. Sometimes, though, it's a little easier. You can observe. So, Thomas, what do you see here?
So you have persistent extension of the ring finger. Looks like the person's trying to tenodecim, so likely flexor tendon injury.
Yeah, exactly. So at the very least, this kid has a flexor tendon injury. It needs to be explored. Should end up having a little bit more than that, but at least here, you can see. So, so you can observe, in a case like this. So we're starting to see that, maybe the kids' exams, you can get some exam out of them. They don't have to follow the classic way that you would examine an adult, but you can get things out of kids that you wouldn't actually normally do in an adult. So here's one skill. You can observe, like Thomas says. How about this child? So he sustained. So this kid, they were out in the yard. They live right down the street from me. And this kid is a little kid, and his older sister was pruning the bushes with pruning shears and then pruned this kid's pinky. So kid comes into my office. He's got chromic sutures in. The ER resident feels terrific about themselves because they said, yep, we probed the wound. There were no exposed tendons. We sewed them up with chromic like he taught us to, Dr. Apo, and the family's all happy. So the family comes in and, how can we determine whether or not there's been a laceration to the ulnar digital nerve in this kid, right? That's the question. So what we did, James, you know how we can tell? Presence or absence of a digital nerve injury in a child? I'll give you a hint. His hand is all wet right now.
Oh, like skin wrinkling?
Yeah, it's a skin wrinkling. So it's called the warm water immersion test. It's a real thing. I didn't make it up, I promise. And you just soak the hand in water. And you can see here how the middle finger and the ring finger are wrinkled, but the pinky finger is not wrinkled. And that's because skin wrinkling is a neurological response, neurologically mediated response. So the lack of skin wrinkling here demonstrates that there is a digital nerve injury in this kid. And that's exactly what we found on exploration. Had about a 98% laceration of the digital nerve, essentially of all of the neural elements. So this was performed just with a simple, resection back and repair with a tube. Here he is 6 months later, same test performed. And you can see all the wrinkling in the skin. So we have other ways of examining children. We don't have to have them use the monofilaments or ask if they can feel me touching. We can do other things. The warm water immersion test is one of them. Here's another great example of that test. Here's a kid that had a known median nerve injury after a supracondylar humerus fracture. But here they are with a warm water immersion test, just really illustrating the findings here. You can see that the thumb and the ring and the pinky finger have all come back nicely with excellent wrinkling, but the pointer and middle finger are not wrinkled yet. So this can be a pretty dramatic finding. So moving on to other aspects of care, I want to talk about aftercare for a little bit. So the first obvious question is, do we prescribe therapy for kids after injuries? There's a couple of areas where we know the answer to that. So flexor tendon repair, for example, we know that in kids up to adolescence, that 4 weeks of immobilization is not detrimental. There have been studies that have compared simple immobilization of flexor tendons versus formal flexor tendon rehab protocols, and really found no benefit to putting them through formal flexor tendon rehab. There was a level 1 study published about 7 years ago for looking at after supracondylar humerus fractures that found no benefit to therapy, and actually it showed that it made the kids' anxiety worse, that they had worse anxiety if they went to therapy afterwards. And so by and large, we don't prescribe therapy for children. That the job of a child is to play, and their play is sufficient for them to restore range of motion and to restore function. And they're able to do that much better than a therapist could in a very artificial session. A couple of other things to remember about children when it comes to their aftercare is remember that they're non-communicative post-op, just like they are pre-op. And so they can't tell you about things that could be problematic, like a dressing that's too tight or casts that are too tight. So, when I think about aftercare for kids, what the important points are, I think of it like Ferris Bueller. What are we going to do today, Ferris? It's not what are we going to do, Sloan. It's what aren't we going to do? So let's just think about some things that we're not going to do in kids. So first off, we're not going to leave the finger tourniquet on, okay? I only mention this because it's been done before. So if you're going to do a little fingertip repair in a child, just make sure to take the finger tourniquet off. They can't tell you that they still have it on and that their pinky is painful. So you got to remember to do these things for them. So we don't ever put circumferential dressings in children. So here's a kid who had a rather innocuous index finger injury that somebody put some stitches in, and then they went to put a dressing on, and they put the dressing too tight. They ended up wrapping the dressing too tight around this finger, and it led to ischemic necrosis. You can see here, we put giant dressings on fingers, even for something like this, which is a single digit. We put this giant dressing on. And you might ask, well, why so much dressing? Well, the answer is that, first off, there's no morbidity to a large dressing, right? Again, kids don't work. It's not like it's going to get in the way of their job. They don't live alone, and they're not going to get stiff. We put this giant Christmas cast here on this kid, this long arm mitten cast. His elbow's not going to get stiff by being in a cast for 3 or 4 weeks. And so there's no drawback to it. For a kid, it's impossible really to wrap up a single digit because it's little and you want to not make it too tight. But for the whole hand, it's easy. It's easy to wrap this thing up like a Q-tip and then cover it up with a cast. The large dressing is also much easier to keep on. You can see here we have that elbow at 90 degrees. And so he's not going to escape out of there. We did a case a couple of weeks ago, similar type situation. Only a younger kid, little chubby little 18-month-old toddler. We put him in a shoulder spica because the chubby kids can get out of the long arm casts. We had to cast them in some extensions. We added a shoulder spica. So you got to remember, these kids are Houdinis, right? They're going to get out of your dressing. But we have the ability to make casts that kids can not escape from. So that's what we do. We put them in casts to keep the dressings on. So, why does it have to be loose? You got to remember, kids can't verbalize like adults. They can't tell you if the dressing is too tight. They can't drive themselves back to the ED, and if you've done your job right, they can't take their dressing off. So it's our responsibility. It's your responsibility to ensure that the dressing is loose enough, that it's not wrapped around the fingers too tight or wrapped around the antecubital fossa too tight. It's our responsibility. So we have to have a high level of vigilance when we're applying the dressing, and remember that. And this is something that's easy to be relaxed about after a case. You've fixed the finger or pinned the elbow or reconstructed the thumb, and it's all smoking and joking, and you're putting the dressing on, you're not paying attention. It's easy to put a dressing on that can end up being injurious to a kid. So you got to be very attentive to that part of the case. So keep discussing further about aftercare in children. Casts are very well tolerated. Casts in children are well tolerated. There's a societal expectation that kids are in casts all the time. Parents rarely request to have them removed early. And so, I think the very liberal use of casts will really help with your aftercare. Narcotics in children are not needed for nearly all pediatric fractures, including some femur fractures in younger children. Certainly, there's been level 1 studies to show that this is unnecessary for elbow fractures. And in general, I find them to be problematic because they can mask the symptoms that you're trying to look for. They can mask compartment syndrome. They can mask tight dressings. And if a kid's getting narcotics, then they're not going to respond with their crying and their pain behaviors that are going to alert you to something that might be problematic. So the other thing too, just remember about kids, they're always going to surprise you. They're going to be able to get out of your casts. They're going to do things like this, like wear out the plantar surface of your little short leg cast. They're always going to surprise you. So just don't be surprised when they surprise you. I guess that's all I can say. So I want to talk about a couple of specific injuries. So we can talk about, I want to talk about pediatric fingertips, because these are really common. Kids slamming their fingers in doors. And so I think probably one of the most common questions that I get asked is, well, do we need to be given antibiotics? So the short answer is no. And here's the reference for that. It's now over 10 years old. This was a prospective randomized controlled trial that was looking at fingertip injuries in children, over 100 patients. And they really, found that antibiotics made no difference in uncomplicated fingertip injuries that are repaired in the ER. So you can, and this is very common, you'll see the urgent cares want to give it to them, the ER wants to give it to them, but you're the specialist now. And so you can tell them, look, there's ample evidence to say that you don't need antibiotics for fingertip injuries in children. Another question I get asked a lot is about use of Dermabond. And, Dermabond is, it's a blessing and a curse. I think the blessing of it is what this study showed, which was that, again, almost, over 10-year-old study, but showed that for uncomplicated nail bed lacerations, that there's no difference in outcomes by using Dermabond. I think it's fine to use in children. What I've seen a problem in practice is that people think that once they open the package of Dermabond, they can just forget their brains, and they don't manage other things appropriately. They don't take the nail off. They don't wash out the injury. They think that there is purple magic inside of the capsule of Dermabond, and that it can just cover up all manner of medical mismanagement. So my take on it is that you really have to manage the rest of the fingertip appropriately. You got to numb it up. You got to put your finger tourniquet on. You got to take off the nail and you got nail plate, and you got to wash it all out. And if after you've done that, you want to repair the nail bed with Dermabond, that's fine. It actually works pretty well, and it's kind of slick, and it will actually take you less time. But that doesn't mean that you can just put Dermabond on top of an avulsed nail plate that's all bloody that hasn't been properly managed. Well, Dr. Apel, what if the whole fingertip is ripped off? Well, young Padawan, you can just sew the piece back on, seriously. And here's an example of that. And sometimes you may have heard this called a biologic dressing, and this is what it looks like. Sometimes it's called a composite graft because it's several different tissue types. But this is what it looks like. Hardest part about this is convincing the family that it's going to be okay. So I keep these stock photos to let them know that it's going to end up healing up beautifully. And so here's the final result. This is about an 18-month-old toddler, but it ends up healing beautifully. Probably a combination of some take of the graft, and it mostly is probably granulation and regeneration underneath the graft, but it ends up looking great. A couple of other things to think about is suture choice. So the suture on the left here, you see this is a monochrome or a chromic. It's clear. And on the right here, you see this little baby hand with nylon suture in it. And so, this is really problematic when we have nylon suture in a hand, because it's got to be removed. This kid's a little wiggle worm and terrified of doctors and anybody else medical, and is going to be screaming and thrashing around trying to get these sutures out. So, this is a screenshot from an op note. This is why we don't put non-absorbable sutures in kid. This was a kid that had, I don't know, like probably 30 or 40 sutures all over the place, in his head, in his neck, in his wrist, in his hand, from a dog bite. Had a bunch of nylon sutures, and he required a return trip to the OR just to take his sutures out. in a toddler. So this is why we don't put non-absorbable stitches in kids, and they just don't need it. You know, the skin heals up in fast enough time that a chromic or even a fast gut is going to hold the wound opposed for long enough that the skin will just heal up before the suture fails. So here's a more typical look. This is just a thumb duplication repair. You know, repaired up with monocryl. This is what that should look like. So moving on, you know, I want to talk about this case because I think it's very demonstrative of what not to do. So here's a case of some exposed bones. This is a kid that got his fingertips caught in a bicycle chain. So transverse amputation at the long finger. Index finger is really just a nail plate injury. Here are the x-rays. You can see all the bone is there of the middle finger. So, you know, not sure how they would be told to manage this at your institutions. But this case, this is probably a decade-old case, but the resident taking care of this case was told, oh, just rongeur the fingertips back and close it on up. And that's exactly what they did. But here we are now 6 months later. And Sahil, what do you see here? What's this called?
Looks like he's got a hook nail deformity.
Yeah, that's exactly what you have. You have a hook nail deformity. And so when you look at the lateral here, that middle finger, what's missing?
He's missing the tuft of the fingertip there, so there's no support in the nail matrix.
Yeah, so that's an iatrogenic bone loss there. So that bone was not taken out by the injury. That bone was taken out by a stainless steel rongeur. So this is wholly an iatrogenic deformity here, because had this been treated with simple granulation, it probably would be a perfect fingertip. Instead, it's got this hook nail deformity. So the lesson is, don't remove bone in children. I would actually extend that to adults and say don't remove bone in anybody, but that's a separate talk that's, you know, beyond the scope for this morning. And here's what that looks like. It's the hook nail deformity, like Sahil said, and what it is where the nail grows down because there's not enough bony support up underneath it to keep it from growing, to keep it growing out straight. So for fingertips, you know, going over the teaching points for fingertips in children, don't remove bone in pediatric cases. And I implore you to not let anyone else remove bone either. You know, we need to, you know, as advocates for children, not just do the right thing ourselves, but ensure that those around us do the right thing. And if you hear somebody else say, oh, just rongeur back that fingertip in that kid, you need to speak up and say, hey, that's actually not the right thing to do. Remember that, you know, adult techniques are not appropriate for kids. This idea of just shortening fingers in adults is pretty common. But remember, kids are different, right? They tolerate flaps. They can be put in casts. They don't have to go back to work. They're going to have insurance, so they can come back for surgery, you know, in a week or two. And they're going to have a full-time caregiver who will be able to wait on them and bathe them, entertain them, you know, take them to and from doctor's appointments. So you can do things in kids that you wouldn't necessarily do in an adult, you know, like a thenar flap or a cross finger flap or something like that, to get a better result out of a fingertip. And remember that the nail bed must always have bony support, and that's why you can't remove bone or you'll end up with that hook nail. So briefly, I'll wrap up this morning. I'll just show you one last case. It's going to be a toe because it's the only example I have for it. But it's a 10-year-old male, you know, toe injury 2 weeks ago. Told it was just a bad stub toe. So here's his injury. Remember, the big toe is just a thumb, dirty thumb. And you can see here. So Kara, what do you see here?
So he has a fracture through. He's a physial fracture.
Mm-hmm.
I think is it the epidemic Seymour?
That's a Seymour fracture. That's exactly what it is. So a Seymour fracture is this Salter-Harris 1 or sometimes 2 of the distal phalanx. And what happens is the germinal matrix gets incarcerated in the fracture. It's an open fracture that stays open and it has a very high likelihood of infection. And then it always goes on to a nail deformity if it's left untreated. You know, and here's what this kid looked like. It was obviously infected when he came in because this was an open injury. Here's one. These are taken out of Green's textbook because I didn't have one for my files. But here it is. You see more fracture right through the base of the distal phalanx epiphysis. They've opened it up here in figure B and fishing it out. And then there's the nails that's growing back in. You can see the little deformity there in B, part B. So that's it. Any questions about how we take care of children, fingertip injuries, or pediatric fractures?
Dr. April, I do have a quick question about dressings. So I've been told by some people, like if you cover up, like if you have a fingertip injury or something of that nature, and you cover the kid's fingertips, that the parents might get, kind of bent out of shape, that they can't see their child's fingertips. They can't like check for the perfusion, and you've been mentioning some very tight dressings that might have been beneficial to see the fingertips. But do you tend to keep them exposed, or do you like to like overwrap them with like that club cast or that club type dressing?
Yeah, so I put them all in a club type dressing or club type cast, and I explain to the parents that, this is like baking a cake. We've gotten everything perfect, and we're going to put it in the oven, and we're just going to let it bake, and we're just going to let it heal. We're not going to peek open the oven, every 3 minutes and check on our cake. We're going to leave it there. And so, this is part of where, so parents aren't doctors, and they can't really be expected to check for anything in a meaningful way. And so, I don't rely on parents for any of my aftercare to do anything medical other than drive the kid to and from the appointments and use their parental instincts. If they feel like something's wrong, bring the kid in. But I don't require parents to check capillary refill or anything else like that. I mean, every single case of compartment syndrome of a child that I've taken care of, the parents have been at bedside, or every medical legal case that I've reviewed where it was missed, the parents were there with the child. So don't rely on them as being your medical sentinel, because they're not. They're non-medical people. So no, to shortly answer your question, no, I don't leave the fingertips exposed. I cover everything up.
Thank you.
All right. Well, everybody have a great morning, and we'll see you next week.
Thanks, Dr. April.
Thanks, Peter. Bye.